Welcome to another episode of PT et al. Today we have Dr. Jeremy Kushner. How are you, Jeremy?
Doing well, Dr. Payton.
Yeah, we're going to talk a little bit about manual therapy, but first I'd like you to kind of tell us and the listeners a little bit about yourself.
Right. So I work for St. Luke's as a physical therapist in the Lehigh Valley. I manage an office there. I am board certified in orthopedics. I am a certified manual therapist through Evidence in Motion. I am a part of their residency faculty for the OCS and orthopedic physical therapists. I'm kind of keen interest in treating chronic pain and pain neuroscience education. But I also like treating athletes and other orthopedic conditions.
Great. So you sent me some different content to look over before we have this discussion now. And one of the main articles that I'd like to point the viewers to is Unraveling the Mechanisms of Manual Therapy, a Modeling and Approach. I'll have a link to that below in the description. The first question I really want to ask you is, are we as physical therapists explaining what we're doing with our manual treatment well enough to the patient that makes sense, that we're doing what we're actually doing, and for them to understand it?
Yeah, I think that's a good question. I mean, I think when we explain our interventions to our patients, they have consequences. And the way that we really have learned manual therapy in school and maybe even continuing education courses have been heavily driven on a biomechanical basis or biomechanical theory. And really, the literature just does not really support that theory as well as we once thought. So our explanations that I see a lot of clinicians tend to be more biomechanically driven, and that's not necessarily how our interventions are effective or how they're kind of working. So I think we really, as a profession, need to move forward with how we're explaining things to make sure that patients clearly understand the effectiveness of how we're making them better.
So when you say biomechanical, we're talking kind of joint alignment. If that's not the ultimate goal of manual therapy, how is our manual therapy working?
Right. I mean, that's like a loaded question in itself because, right. So a lot of what we learned was considered a corrective theory where we're looking at joint position and we're looking at symmetry and we're really trying to make things open and close and we're looking at mechanics of the spine. But how our interventions are effective from a manual perspective tends to be more neurologically driven, or what the literature deems neurophysiological effects. And these effects are quite robust. And we clearly don't understand exactly how manual therapy works because it's a very complex it's a complex way of studying it. It's really hard to study manual therapy because there's all these different types of interventions and there's a lot of effects that occur. So it's hard to kind of control all of those variables. But as a whole, the literature is really pulling us in a certain way. And this way tends to be more so looking at the nervous system and the brain and like non-specific effects that occur.
So when I think of manual therapy, we think of our joint mobilizations, grade 1 through 5, soft tissue mobilizations, but there's also what I came across a few times was neurodynamic mobilizations. Can you kind of explain a little bit more in depth what that is?
Absolutely. And I use these quite frequently in my daily treatments. But a neurodynamic mobilization is pretty much a force on a peripheral nervous system. You're trying to inhibit pain or actually make something better based on moving the nerves, because we understand nerves move independently of other muscle tissue. So we could glide the nerve, we could tension the nerve, we could cause excursion of that nerve. And we know that in terms of pain processing, that nerves carry important information to muscles, and they also have an ability to become sensitive. And nerves need space, they need blood flow, and they need movement. So a neurodynamic mobilization is a force imparted on the peripheral nervous system to have an effect such as inhibiting pain or improving motion.
So how are you explaining to your patients what you're doing with these glides and tensioning?
So as a whole, the way I explain manual therapy in general to my patients is a very blanket statement. We need to impart some movement, some mechanical movement. So when we're doing any type of manual therapy, whether it's a nerve-based treatment, if it's a joint-based treatment or muscle-based treatment, there is clearly a mechanical force and this biomechanical force that is imparted on the patient. But the effects of what we do tend to be more neurologically driven. There tends to be more transient neurological changes, no matter really what we're doing in particular. So I would explain that what I'm doing is imparting a force to, or imparting a motion to a specific nerve or muscle, and that's causing transient neurological changes that may inhibit pain or facilitate the muscle to relax. But then there's other non-specific effects that occur to someone's pain, where it could be their expectation and the environment, and actually my expectation on if something would work and how I deliver that message to the patient to have an effect or have a pain relieving outcome. So it's more of a blanket statement rather than discussing the individual nerve that I'm moving or the individual joint or the individual muscle tissue that I'm trying to mobilize.
Do you ever have discussions with physical therapists or even chiropractors, other health practitioners, that really, jumping back to our previous statement, that they are aligning joints, they are moving ligaments and tissues to increase mobility? And how do you get your point across to them and getting them to think a little bit differently if you really are kind of at the debate podium trying to change people's mind? What's the one thing you want people to think about?
I think it's a really good question. I mean, and it just depends on what audience I'm speaking to, because right, I work in an office with many doctors of physical therapy, and our type of treatment is going to be different than maybe a chiropractic treatment. And I'm not trying to stereotype a profession, but it's really hard to explain these effects to patients who have already been to chiropractors for years, who have been heavily driven by a mechanical explanation, because it's easy, right? If they have faulty positions of the spine, they're going to keep coming back for adjustments so that they could be aligned again. So when I'm having a conversation with a patient, it's a really slow drip type explanation to them. But if I'm having a conversation with another healthcare practitioner, like a physical therapist or physician or a chiropractor, I really ask them specific questions on how they believe something is working, because this whole corrective theory or this biomechanical theory has really been perpetuated for a long time, and the evidence currently just doesn't show that it's reliable. So we can't be just driven in evidence. That's kind of what drives medicine, but we have to account for our experiences and our mentorship. So we have to really kind of slowly tease in the evidence-based practice behind how we're explaining our interventions. And I always come back to several different, there's a few research articles that I like to pinpoint in particular for those people who are just resistant to change, if you will. But we still see a lot patients being explained by different physical therapists that their joint is out of aligned or their rib is out. So when we impart a force back to the ribs, we're actually placing the rib back into place, or the SI joint comes out of place and we're using a muscle energy technique to put it back into place. So I really think that it takes some time to explain this type of intervention, especially to the providers who are actually doing manual therapy on a day-to-day basis. But it really doesn't take much beyond a few simple articles of reading to grasp the kind of neuroscience behind how manual therapy works from what we know today. Like I said before, we still don't exactly know how it works, but the research is gearing us down this pathway of these neurophysiological effects. I think once you could get an understanding of that, it's an easy explanation to go on rather than perpetuate this biomechanical theory, which we're trying to move past as a profession.
I completely agree. Does everybody have the ability to benefit from manual therapy if they're in pain? And let's include, if you could talk a little bit about the potential psychological benefits, a la placebo effect.
Yeah. So I don't actually think that everyone will benefit from manual therapy. And the reason why I say this is because there are some patients that cannot modulate their own pain. And that's going to be troublesome because those patients that we see with 6 months plus of pain who may have a centrally sensitive nervous system. We hear of central sensitivity in the literature and physical therapy and medicine, where I think it's now 1 in 3 people in this world have chronic pain, or maybe 1 in 4 people. And those patients may not do best with a manual therapy treatment. It's just because they can't really modulate their own pain. And the way that the structure of the nervous system is, there's neuroplasticity where they can't modulate their own pain like someone like ourselves who aren't in pain. So I still use it. I'm still a heavy manual therapy utilizer. And I try to make manual therapy as adjustable as possible, where I try not to make people rely on it. I try to use it and then do something else so that I could get someone to modulate their own pain. But yes, even in my anecdotal thought process, I really don't see everyone benefiting from manual therapy, especially with those patients who are having a hard time modulating their own symptoms. That being said, manual therapy does have a profound placebo effect. And when we think about a placebo effect, we can't think of it in like a randomized controlled trial where you either get an active ingredient or you don't get an active ingredient. This is more of, when we think about a placebo, we really think about a mechanism where our effectiveness of manual therapy is driven by expectations and conditioning. Those are the two big, I would say, psychological or non-specific aspects on how manual therapy benefits people. Because if someone is coming into your office, they're getting a very skilled treatment by a highly skilled provider. And we're basically teaching these patients what they should expect. So we're telling them that this is going to be an effective intervention for their pain. They either have known someone who has benefited from physical therapy or manual therapy, or they themselves have benefited before. So when we think about a placebo being a mechanism on how manual therapy works, it's really driven by those two factors. And there's really more detail that we could go into based on someone's expectations, because there's literature now supporting that how we speak with our patients could actually change how that intervention worked. And conditioning too. If someone is conditioned to expect an intervention to be effective, they likely will have an effective intervention. So it's really interesting on how non-specific effects can impart a positive effect for patients when it comes to manual therapy.
And kind of talking about the non-specific nature of it, part of the literature that you sent me talked about the benefits of mobilizations on the spine, non-specific to the location that you're applying the forces.
Right.
So how many segments above and below are we looking at for mobilization on, say, T4?
Like in terms of movement, you're saying?
Yep.
Yeah, I mean, I think that if you mobilize the upper lumbar spine, you're still getting some degree of motion in the lower lumbar spine.
Mm-hmm.
Same thing with the thoracic spine. If you're going to, mobilize the thoracic spine, you're still going to get a degree of movement elsewhere. And that's where we think that our interventions don't have to be as specific as we once thought, especially when we're cavitating a joint or when we're doing a grade 5 mobilization at the spine. There's specific literature that shows that when we impart a grade 5 mobilization to the lumbar spine, that we may or may not be targeting the area that we thought we could. And the same thing with the thoracic spine. But the effects tend to be positive. It's not necessarily the location that we're looking at things, but more so the effectiveness, or kind of looking at how the effect occurred after we performed a manipulation, whether we're testing and retesting. I think that's the key. But yeah, overall, the results show that what we do is really more non-specific when we impart a joint mobilization.
And in your own practice, in what part of the treatment session are you performing your manual therapy? Because I believe in the literature I saw something along the lines of a 20-minute to 5-hour window of where the most benefits of a manual treatment are going to be allowed for, where they can probably respond best to some other follow-up treatment.
Right. So that's correct. The effects of what we do can last 20 minutes to 5 hours. That's like the most we see from a literature standpoint. But really, some of the literature only shows 5 to 10 minutes. So that being said, how I drive my treatment sessions are geared towards within session improvements. So I want to test something, and I objectively test it. I know that's concordant to their problem that they're coming in to see me. I impart a treatment on it, whether it's a therapeutic exercise or manual therapy, and then I retest it to see if I've made the outcome that I want. So I guess I'm using it quite frequently throughout the treatment session. I'm not the type of therapist that just will line up a bunch of manual interventions and do one after the other. I do one and I assess my asterisk signs to see if I want to carry out that intervention again. It really helps save time, because if what I'm doing is kind of lumped into treatment session, I don't know exactly what's helping my patient, I'm kind of wasting time. I'm not really performing the best optimal and efficient treatment that I could provide. So I'm using manual therapy throughout the entire treatment. But I'm also doing exercises and trying to follow through. I call it an augmented program, right? We're going to augment our intervention, our manual intervention, with some type of exercise. And if that made a good result, I'd be able to measure it and see the change.
With a kind of a strong focus on manual therapy like you have, do you find that you have a different home exercise program approach than some of your other fellow therapists?
My home exercise program is pretty unique, just because I want to make sure that it's very specific to what my patients are having. It may be as simple as, for someone who has a thoracic problem, I may just have them do simple thoracic extensions because that's helped modulate their problem. So I'm really trying to find specific asterisk signs that I'm looking for in my evaluation. And if a movement pattern is going to change that or help modulate their problem, I'm going to repeat that. So it's definitely not a cookie cutter approach. And most of the therapists in my office, they are very similar in that aspect where we try to provide an individualized approach. But again, it's really geared towards that patient specific complaint. It's not based on a diagnosis. It's not based on just general things that I think they're going to benefit from. It's based on pain modulation and what we can do to help that patient immediately.
I think it's pretty common for most therapists, as we were taught in school, to use grade 1 and 2 mobilizations for pain relief, 3 and 4 more for to getting into those changes where you're creating some more increased motion in the joint, and then 5 for significant increased changes. We kind of talked about the joint alignment and how that might not be really what we're looking for, but if we're talking about shoulder, knee, hip, outside of the spine, how often are you doing those different grades of mobilizations?
I am doing them every day. So I think the way that I drive my treatment is not necessarily based on that type of reasoning, right? I'm thinking more about tissue irritability levels and symptom severity, and that's what's driving my interventions. So if someone doesn't have high tissue irritability levels and they're lacking motion, I'm going to go into a grade 4 and maybe a grade 5, depending on if I think that's going to be a beneficial intervention for them. So those things that we learned in school aren't necessarily what is driving my thought process behind it.
Is there any new evidence on mobilizations that people who have been out of school for, say, 5-10 years has changed and people might not be aware of?
Yeah, I mean, in terms of like different grades of mobilization.
Yes. Yep.
Yeah. So I think that we could look back at one study that Chad Cook and his colleagues looked at was the difference between a thrust and non-thrust mobilization. And it's such an interesting article because people always focus on the fact that there were no significant changes between a thrust and a non-thrust mobilization directed at the lumbar spine for immediate pain relief and immediate improvement in range of motion, as well as second follow-up and discharge. But the interesting thing about that article that people really don't delve into is they looked at what's called clinical equipoise or equipoise. And the therapists that conducted the manual interventions in his study, they were graded as to whether they like to use one technique over the other. And when they looked at the statistical analysis, there were no differences between the both. But the individual therapists that did not have equipoise and they preferred one treatment over the other actually had more of an effective intervention on the aspect of what they preferred. So that's like, it's great. It's so hard to think about, but our beliefs as therapists can change someone's response to the intervention. So as a whole, there may not be a whole lot of difference when we looked at it from a huge 30,000 foot view, but when we look at individual preferences, that could change. That could change someone's bias or change someone's effect on manual therapy. Isn't that pretty interesting?
That is. That it certainly is. That's and I'll have a link to that article below. Hopefully Jeremy can direct me towards that.
I can do that.
So the final question I have for you is, there's a lot of therapists, myself kind of included, who don't do really grade 5 mobilizations or thrusts on the cervical spine. It seems like we hear every 2 or 3 years of someone who is now deceased and they're directly correlating that with that type of procedure, usually due to some type of arterial occlusion. I want to know if you do those And if so, do you think every therapist should do those if appropriate?
Right. I think they are in my practice. They are in my skill set. I would say that I am not using them as frequently as I would a thoracic, which I do every day,
Absolutely.
and lumbar. And I think probably the biggest thing, the reason why, is not necessarily my fear, but it's patience. It's patience expectation, right? When we think about doing a specific intervention for someone, I typically ask them what they expect from it, or if they've ever had it before. And a lot of our patients are afraid of it. And that's because there's so much negativity in the media regarding cervical manipulations. But really, if we do our due diligence as a profession and screen the cervical spine, it could be a very, very, very low adverse risk events with cervical spine manipulation if you do a thorough exam and ensure that the cervical spine could withstand that force. So yes, for patients that request it, I'm absolutely doing cervical spine manipulations. But again, it tends to be more driven by patients and how they respond when I let them know that this may be an effective intervention for them. Some will say, I'm just not comfortable doing it. I think that's fine. Because we know that a mobilization could be just as effective for a specific pain pattern that someone may have in their cervical spine. So there is more research that's looking at blood flow in the cervical in the cervical arteries, I should say. And there's really not a drastic amount of blood flow change in some of these studies. I mean, it's really inconclusive, I would say. So we as a profession really need to hone in on some of those studies that show that there's conflicting evidence in terms of how much blood flow is occluded by end range rotation or end range extension. And there's really mixed results in the literature from it. So I think that it's good to understand it and understand what your patients may want from it, because again, I'm driving my treatment based on patients' expectations. And if they think that something's going to be an effective intervention, I'm going to make sure I do that for them.
Well, Jeremy, I think you have given us a lot of insight into manual therapy, a lot of good stuff in our conversation we had here. Is there any final thoughts or anything you'd like to say to the listeners?
Yeah, I mean, I think that as a whole, we could really do a better job at understanding the mechanisms behind how manual therapy works, because, our words do have actions and consequences, I would say. And it's really important to understand how these things how patients may benefit from these interventions. So if we're driving ourselves more towards an evidence-based approach, I would definitely consider looking back at the neuroscience behind pain and the neuroscience behind how this works, because it could really help you change someone's perspective and really help you maximize benefits from your manual therapy techniques.
I think that's very well said. It's always a pleasure talking to you, Jeremy, and I hope we get to have another one of these discussions soon.
Absolutely. Thank you.
Thank you.
Take care.